Good afternoon, everybody, and welcome to the first instalment of the 2021 series, Kirby Institute Seminar Series. I'd like to begin by acknowledging the traditional custodians of the many lands on which we meet today and pay my respects to elders past, present and emerging. I myself am chairing this meeting from the lands of the Bedigal people. And I extend that respect to Aboriginal and Torres Strait Islanders who might be joining us today. So my name's Tony Kelleher, I'm the director of the Kirby, and I want to start with some housekeeping issues to start with. So we're going to have two presentations in the seminar today, and we will leave the questions till the end. And so we have a combined question and answer session at the end from both the speakers. To ask the question, I'd ask you to click on the icon with the question mark in the center of it and to type your question into that tool, and then it will appear on the screen. You can upvote questions that you like, which will be given more prominence. And if you designate your name associated with that question, that will make answering the question easier to direct for both myself and the speaker. So our first speaker today is Mallory Trent, who is a PhD student at the Kirby Institute with the Biosecurity program here, which is led by Professor Raina MacIntyre. Her PhD is entitled Barriers and Enablers of Vaccination Informing Whole-of-Life Vaccination Policy, and is focused on gaining a deeper understanding of vaccine hesitancy and assessing current vaccine policies in Australia. I'll hand over to Mallory now. Thanks, Mallory.
Thanks, Tony, and thanks to everyone for tuning in. Can I just confirm that you can see my slides all right, Tony?
All good.
Perfect. So before I begin, I would like to acknowledge the Bedigal people, who are the traditional custodians of the land I'm presenting on today, and pay my respects to their elders past, present and emerging. As Tony said, I'm a PhD student with the Biosecurity program, and my PhD is focused on vaccine hesitancy in Australia, with a particular interest in understanding the barriers to adult vaccinations like influenza, pneumococcal vaccines, and now COVID-19 vaccines. One of the big takeaways from my research so far has been that adult vaccine hesitancy is really different from parental vaccine hesitancy, has different barriers, and is somewhat under-researched. So last year, when COVID-19 vaccines started to be developed, I was really interested in trying to understand what did the general public think about those vaccines and how might that influence uptake further down the line, given how political the COVID-19 response has been in some countries. So, as part of a larger survey that we did on mask use and other preventive measures against COVID-19, we surveyed a fairly large sample of adults from 5 cities in the US, the UK, and Australia. And I'll be presenting some of those findings today. So, as you all may be aware, last week we reached a rather unfortunate milestone in the pandemic. The 100 millionth confirmed case of COVID-19 was reported since the pandemic began. Just in the US alone, there's been more than 25 million cases, which works out to more than 7,000 per 100,000 people. In the UK, there's been more than 3 million cases, but in Australia, we've been fairly fortunate. So far, we've had less than 30,000 cases, which works out to an incident rate of only about 113 per 100,000 people. And we've managed to do that through, effective contact tracing, border closures, mandatory quarantine, and other policies like that. But in the US and the UK, they're still seeing thousands of new cases per day, and that's the same for many countries around the world. So really at this point, it's likely that the pandemic is not going to be brought back under control until a sufficient proportion of the population has been vaccinated against COVID-19. At the moment, there's 66 different vaccines in clinical trials, and some have already been approved for use. In the US, they've already approved the Pfizer and Moderna vaccines, and they've already administered, I think, about 30,000 doses to healthcare staff and other essential workers. In the UK, they've given emergency approval to the Pfizer, Moderna, and AstraZeneca vaccines, and have already given about, I think, 9,000 doses so far. Australia recently approved the Pfizer vaccine for use, and hopefully vaccine rollout will start in about the next month or so, depending how vaccine supplies pan out. So some modeling studies have shown that with an effective vaccine like the Pfizer vaccine, about 70% of the population needs to get vaccinated before the pandemic is going to be brought to a close. However, the problem is that a lot of early surveys have shown that as much as a third of the population may not actually take the vaccine, even if it's available to them. So as important as it is as developing safe and effective vaccines and assuring that they're widely available, none of that counts for much if there isn't enough demand to even make sure that we reach that 70% target. So the goals of this study were to get a rough estimate of how many people were willing to receive a COVID-19 vaccine if it were available, try to identify groups that were more or less willing to actually take the vaccine, and identify any potential perceived barriers to vaccination which may influence uptake further on. So we were interested in surveying cities with different COVID-19 incidents, as well as different responses to the pandemic, to kind of see how that might influence attitudes towards COVID vaccines and other preventive measures. So we actually ran this survey from July to September of last year. And since then, the circumstances of the pandemic have already changed quite a bit. So I'll quickly give just a bit of context on these 5 cities that we decided to survey at the time, which were Sydney, Melbourne, London, New York City, and Phoenix. So at the time of this survey, Sydney was still experiencing pretty low COVID numbers, while Melbourne was in the midst of its outbreak and was having about 200 or 300 new cases per day and was in the middle of that 4-month lockdown. London, on the other hand, had just managed to get its first wave relatively back under control and wasn't experiencing many new cases, and they had already started to lift some of its lockdown measures and had made masks mandatory throughout the country in certain public settings. Similarly, in New York City, they had started to get that first wave back under control and were only reporting a few hundred new cases at this time compared to, the 30,000 per day they were having back in March. So they were also beginning to lift some of their stay-at-home orders. On the other hand, in Phoenix, in Arizona, they were in the midst of a really severe outbreak and were having thousands of new cases per day. There weren't any formal stay-at-home orders, but some businesses such as gyms and bars were ordered to close, and in Phoenix, masks were mandatory in public. So just quickly run through the methods. We administered the survey online to a sample of people 18 and over from those 5 cities. All data was collected anonymously, and the sample was recruited from an online consumer research panel from Dynata. Our primary outcome was willingness to receive a COVID-19 vaccine, which we assessed with the question, if a vaccine against COVID-19 was available, would you get vaccinated? Where they had to answer yes or no. To identify factors that were associated with willingness to receive the vaccine, we used a modified Poisson regression to estimate prevalence ratios of willingness to take the vaccine. We were also interested in participant-specific reasons for not wanting to take the COVID-19 vaccine. So we also collected some qualitative data from an open-ended question, which was simply, please explain why you would not get vaccinated. And we used thematic analysis to categorize responses from those answers. So this table is just looking at the basic characteristics of our study sample from all 5 cities. And I won't spend too much time on this, but I just wanted to point out a couple of what I feel are pretty important differences in the samples from each city, particularly when it came to age. So our samples from New York City and Phoenix had a significantly larger proportion of adults who were over the age of 65 compared to those in Sydney, Melbourne, and London, which is just an important caveat to keep in mind when interpreting these results, and we'll see why in a few minutes. The other thing that I found that was really striking was the level of trust and confidence in national government and how that compared between these cities. So, for example, when we asked people to rate the level of trust that they had in the information they received from their national government on the pandemic, about 65–70% of participants in Sydney and Melbourne said high or very high trust in that information, while less than a third of those in London, New York City, and Phoenix rated their trust as high or very high. And we saw similar numbers with their level of confidence in their national government. And again, we'll see why this is important in a minute. So, when we asked if you would get vaccinated if the vaccine was available, at least 70% of people in all 5 cities said that yes, they would take it. This was lowest in London, where only 70% said they would take it, and highest in Melbourne, where 78% said that they would take the vaccine. So this next table is just looking at some demographic and health predictors of willingness to vaccinate against COVID-19. In the interest of time, I'm not going to go through each characteristic, but I'll just try to give an overview of some of the more interesting findings here. So like I said, we looked at a few demographic predictors that we already know are associated with other adult vaccinations. And so for each of those, we've shown prevalence ratios and 95% confidence intervals for each of those 5 cities. The only demographic factor that was consistent across all 5 cities that we sampled was age. We found that as age increased, so did the likelihood that someone was willing to take a COVID-19 vaccine, and the rates were highest among those over the age of 65, which this is fairly unsurprising. This is also tends to be the most consistent predictor of influenza vaccination among adults as well. One other thing I just wanted to point out is that we found that people who smoke tobacco were overall less willing to receive the vaccine, and those with at least one chronic health condition were more likely to want to be willing to receive the vaccine, which is important because both of these groups are also at higher risk of severe disease. But again, this was overall fairly unsurprising. We did a survey back in 2019 looking at predictors of influenza vaccination, and we saw these same trends. Those who smoke tobacco are less likely to vaccinate, and those with health conditions are more likely to vaccinate. So now I'll take a bit of time and look more in depth at some specific beliefs and attitudes that were associated with willingness to take the COVID vaccine. Just for the sake of simplicity, I've broken it down city by city. And we'll start off here in Sydney. So one thing that we were really interested in looking at with this survey was how trust and confidence in government would affect one's willingness to vaccinate against COVID-19. And what we found in Sydney was that these results were largely what one would expect. Those with greater trust and greater confidence in their national government, compared to those with lower trust and confidence, were more likely to be willing to receive the vaccine. Interestingly, though, we saw that those who said that they knew someone who had COVID were less likely to be willing to take the vaccine compared to those who didn't know anyone who had ever had COVID. However, this may have just been due to confounding by age. These folks that said that they knew someone who had COVID were on average a lot younger than those who didn't. And we've already seen that increasing age is associated with increased willingness to take the vaccine. And we also saw that individuals who perceived COVID as more severe were more likely to take the vaccine, which again is something that we've seen quite frequently looking at influenza vaccination. So switching gears now and looking at Melbourne, our findings were pretty similar. Individuals that had greater trust and confidence in their government were more likely to be willing to take a COVID-19 vaccine, as were those with greater perceived severity of the disease. So looking now at London, we were surprised that actually none of these factors were associated with willingness to take the vaccine, which was surprising given how severe the pandemic has been in the UK overall. But it very well might be an issue with our sample size. We only had about 291 participants from London, so maybe we just lacked statistical power to see an association there. So going across the pond now and looking at New York City, one thing you may notice right away is that the results we got here were kind of the complete opposite of what we saw in Sydney and Melbourne. Participants that said they had greater trust and confidence in their government were actually less likely to be willing to take the vaccine. And individuals who said that they knew somebody who had COVID were more likely to take the vaccine. Looking at Phoenix, again, you'll see that increased confidence in government was associated with less willingness to receive the vaccine, which at first was really counterintuitive and kind of goes against most of the existing research on vaccine hesitancy. But you do have to remember that at the time of this survey, the national government in the US was still led by Donald Trump, who has a pretty prolific history of anti-science and anti-vaccination rhetoric. And other research has shown that in the US, one's political affiliation is actually associated with one's willingness to vaccinate against COVID and other diseases. So when you look at it through this lens, it does kind of make sense, and it shows the effect of how political the COVID response has been and how that may be influencing vaccine confidence. We also saw that in Phoenix, perceived susceptibility and perceived severity of COVID-19 were associated with increased willingness to receive the vaccine, which we actually didn't see across the board in all 5 cities, surprisingly. Which may be due to the fact that at the time of this survey, the COVID situation was really a lot worse in Phoenix. They were in the midst of a very severe outbreak, whereas in New York City, London, and Sydney, we had sort of passed the first wave of the pandemic, and it's possible that a lot of people thought that the pandemic was essentially over and didn't perceive their risk to be that severe anymore. So now that we've gone through those predictors on a more quantitative level, let's take a look at individuals' reasons for not wanting to take the COVID vaccine. So after asking whether participants would be willing to receive a COVID vaccine, we asked them to explain their choice. As I mentioned before, we used thematic analysis to categorize these responses. Out of the 700 or so that said that they wouldn't take the vaccine, 627 gave us a reason for not wanting the vaccine. And from their responses, we identified 5 main themes, some of which we broke down further into sub-themes. So actually, the most common reason for not wanting to take a COVID vaccine was no reason at all. more than a third of participants didn't actually have a reason. They said, I don't know, I have nothing to add, just because, something along those lines. And then another 21% also said that it wasn't that they didn't want it, it was that they needed to wait a while, or they needed more information before making a decision. So, and some participants cited concerns about vaccine safety or vaccine effectiveness or other vaccine-specific issues as why they didn't want to take it. And interestingly, some specifically mentioned this idea that the vaccine was too rushed, or they felt that it wasn't going to go through sufficient testing, or that people were cutting corners, things like that. Other participants, rather than mentioning a specific issue with the vaccine, just simply didn't feel that vaccination was actually necessary. Either because they perceived the risk of the disease was quite low, because they were healthy or young, or they felt like it had already sort of passed in their area, or they felt that other measures were better than vaccination. A lot of people mentioned this idea of wanting to build up their own immune system, or just washing their hands, social distancing, other measures like that, and they felt that those were preferable to taking a vaccine. And then lastly, just building on this idea of trust that I've mentioned a few times in this presentation, quite a few participants actually mentioned this word specifically when explaining why they wouldn't take a COVID-19 vaccine. For some, that distrust was specifically at the government. For others, it was at the pharmaceutical industry. Some, it was just towards vaccines in general. Some, it was a combination of all three of those things. Which I think really shows how important trust is in promoting future vaccine uptake. Before I go into any conclusions, I just wanted to quickly discuss a few limitations that I think are really important when interpreting these results. As I said at the start, we did this survey a few months back in July of last year. So COVID hadn't necessarily spread as much as it has now. So we just selected a few cities with different COVID incidents to try to get an idea of how COVID incidents and responses were going to affect people's attitudes towards mask use and vaccines. But that being said, cities aren't really representative of the general population of those countries, especially those who live outside of urban areas. Another thing to keep in mind is that these participants were recruited from a consumer panel, and these are often the subject of bias and may not be truly representative of the general population. So while we hope that these estimates give us a pretty good idea, they may not be precise estimates of how many people really would get vaccinated. Another thing to keep in mind is that vaccine intentions don't always translate to vaccine behaviors. In the work we've done on influenza vaccination in Australia, one of the most common reasons people give for not getting an influenza vaccine is simply that they didn't get around to it or didn't have time. So while let's say 78% of people in Melbourne say that they want to get the COVID vaccine, that doesn't actually mean 78% of people are going to go out and do it. And things like convenience and accessibility are really important when it comes to adult vaccines. Lastly, the survey was conducted 6 months ago, which is a really long time in the scope of the COVID-19 pandemic, and things have already changed a lot, and attitudes may have already shifted, especially considering that in some countries they've already started vaccinating. So just in terms of conclusions, it was sort of tough to pin down a few main conclusions given the sort of broad scope of the survey, but here's what I think they are. So overall, we found that COVID-19 vaccine hesitancy was pretty high across all 5 of these cities that were surveyed. About 25 to 30% of people from each city said that they wouldn't take a COVID vaccine if it was available to them. However, I do think it's really reassuring that more than half of those participants who said they wouldn't take it didn't really have a specific reason or simply hadn't made up their mind yet, which sort of suggests that they don't hold a really fixed anti-vaccination belief, and they might not have a really strong attitude towards COVID-19 vaccines. So they may very well be convinced to vaccinate, especially in a country like Australia, where trust and confidence in the government is quite high. That being said, as you saw, there are some pretty serious barriers to contend with. Vaccine decision-making involves weighing the risks and the benefits of vaccination. And in Australia, where disease incidence has been pretty low overall, individuals may perceive the risks of vaccination to be greater than the risk of COVID-19. Thus, I think really careful messaging is needed on how the vaccine approval process has worked to ensure the public that these vaccines not only are safe, but they are effective, and they are going to be beneficial to people to get them, even if they don't feel immediately at risk of COVID-19. The other thing that I was really struck by was really just how different these surveys, the results were from these 5 cities. To what extent those differences are due to experiences with COVID or just inherent cultural differences between those 3 countries, we can't really say. But I think it really highlights the need for really population-specific data and tailored interventions to improve vaccine confidence and uptake in the future. Before I finish, I would just like to acknowledge my advisors, Raina and Dan, as well as the rest of the study team that I worked with on this survey. Thank you.
Thanks very much, Mallory, for a great presentation. We'll move directly to the next presentation, which is from Professor Raina MacIntyre, who is an internationally recognised expert on immunisation, particularly in adults. She has over 200 peer-reviewed publications, particularly in vaccinology, and has run several vaccine clinical trials with a particular emphasis on those who are elderly and immunosuppressed. She won the Public Health Association of Australia Immunisation Achievement Award in 2014 and is on the Vaccine Council of 100 for the journal Vaccine. She worked for 15 years at the National Centre for Immunisation Research and has led the NHMRC Centre for Research Excellence in Immunisation in high-risk groups from 2011 to 2016. Raina, I'll hand over to you. Thanks.
Thanks, Tony. I'd like to acknowledge the traditional owners of the land of where I am right now, which is the Gadigal people of the Eora Nation. I'm just going to cover some basics of vaccine programs, and these are just my disclosures. I've either consulted for, been on advisory boards for COVID vaccines for Seqirus, AstraZeneca and Janssen, and also consulted for multiple pharmaceutical manufacturers for other vaccines, and as listed there. So when we talk about immunity to infection, immunity can arise from natural infection or from vaccination. But the interesting thing is some vaccines actually generate much greater immunity than natural infection. A good example is HPV vaccine. The HPV virus is very tricky and evades the immune system when you get infected and persists in your body long term. But the vaccine generates this phenomenal immune response that prevents infection. And we've seen the same with some COVID vaccines. The other thing to remember is that immune responses are weaker at the extremes of age, particularly under the age of 6 months, because the thymus, which is the main organ that generates T cells, is not fully developed in an infant until 6 months, but also in the older population over 65. So the basis of vaccine protection is that you give 1 dose of a vaccine, and generally you see this kind of response, except perhaps for vaccines like measles vaccines. You know, they're like the measles vaccine is like the Rolls-Royce of vaccines in terms of the kind of response you get. And in fact, most people get lifelong protection from just 1 dose. But generally you see this peak and then a decline in immunity. And then when you give the 2nd dose, you get this much bigger peak and a more sustained rise in the antibody level. So that's the principle of how you simulate an immune response to the virus in the body by using a vaccine. A really good marker of what we call immune senescence, which is the progressive failure of the immune system after the age of 50, is herpes zoster. And you can see here at the age of 50, and there's a really classic data from a GP called Hope Simpson, which shows this exponential rise after the age of 50. And it pretty much corresponds to an exponential decline in cell-mediated immunity after the age of 50 for herpes zoster. When we look at SARS-CoV-2 or COVID-19, this is a really nice study in the BMJ, which shows the risk of severe disease and complications and death by different risk factors. And you can see that age is far greater a risk factor than any chronic disease. So just being over the age of 50 increases your risk by almost 3 times. So you can see the same exponential increase in risk by age, which pretty much follows that pattern of immunosenescence. I'm just going to remind you again about what R is, which you've heard about, which is the number of secondary cases generated from one index case. So if I have SARS-CoV-2 and I'm in a room with 10 people and I infect 3 people, then the R is 3. The lower the R, the easier it is to eradicate or control a disease. And here's some examples. Among the most infectious diseases we know are measles and pertussis. SARS-CoV-2 is about 2.7, but the new variants can be 4 or even higher depending on what data you look at. But it's higher than influenza, which is about 2. Basically, how you interpret this is if the R is greater than 1, then one case gives rise to more than itself. So an epidemic can occur. But if R is less than 1, then an epidemic cannot occur because one case, it's not sustainable. So R equals 1 is called the epidemic threshold. And every disease control strategy that we use, whether it be a lockdown or social distancing or vaccines, aims to reduce the R below 1. Here's a hypothetical disease. Let's say it's SARS-CoV-2 with an R0 of 3. Here's your first case here. If we vaccinate, so the first case will give rise to 3 cases, and each of those will give rise to another 3, and that's how you get this exponential growth in the epidemic. But if you vaccinate 1/3 of the population, what you're doing is effectively reducing the R to 2, right? So that's the principle of disease control through vaccination. Herd immunity is when enough people are vaccinated to stop sustained community transmission and to protect people who are unvaccinated. And it's generally when you reach a level where enough people are immune to stop sustained transmission, and it can be mathematically calculated based on the R0. The higher the R, the higher the herd immunity required to control the disease. And this is the mathematical relationship between R on the x-axis with the percentage of immunity required for herd immunity or elimination. And you can see that measles with a very high R requires very high proportion of the population to be immune to achieve herd immunity. But we have achieved elimination of measles in Australia through vaccination. We were declared as having eliminated it in 2014. Smallpox had an R0 that's similar to SARS-CoV-2, about 3, and you only needed 66% of the population immune to eradicate that. I won't go into the reasons why SARS-CoV-2 is unlikely to be eradicable, but to control it, it's similar to smallpox. This just shows you the dramatic effect of vaccination on smallpox. So you can see vaccination was introduced here. These are deaths, and you see this huge decline. Still quite a bit of epidemic activity, then vaccination becomes compulsory and it goes right down. And you see this with every epidemic disease. Herd immunity by natural infection does not occur. What you see with natural infection is this. If you just let it rip, this is what you'll see, just cycling big epidemics. This is measles in Australia, and we had quite a lot of measles till 1997-98 when there was this concerted measles control campaign. And that resulted in a dramatic decline and then eventually elimination of measles. So as Mallory said, there's over 60 vaccines in clinical development, but about 170 plus in preclinical development. And there's 4 basic technologies. The first is whole virus. Most of those are inactivated whole virus, but there's one that's a live attenuated virus. Then there's protein subunit, where you're just taking a protein from the surface of the virus and making it through recombinant technology. And then there's the nucleic acid vaccines, which includes the mRNA vaccines. And then there's vectored viral vaccines, where you're piggybacking the antigen that you want to deliver on the back of another virus that is harmless and in general non-replicating. So Merck had a vaccine on a measles virus, but that development was halted. And the AstraZeneca vaccine is vectored on an adenovirus that does not replicate, as chimpanzee adenovirus that doesn't replicate in the body. We have phase 3 efficacy data for some vaccines. Now, these vaccines are generally very cheap. The Pfizer vaccine is a few dollars a dose. The AstraZeneca is a few dollars a dose, but the Pfizer and Moderna are $12 to $14 a dose. That compares to about over $100 a dose for herpes zoster vaccine, pneumococcal vaccine, and HPV. So we have super expensive vaccines on our national immunisation program. Comparatively, all of the COVID vaccines so far are very cheap. They've got full or emergency approvals in some countries, as Mallory went through. WHO has also granted emergency approval for Pfizer, and of course Pfizer was approved by the TGA in Australia. Some vaccines have dropped out of the development race, and that's normal for vaccine development, including the UQ and the Merck vaccines. Unfortunately, the Sanofi-GSK collaboration, which was a protein subunit vaccine, had quite poor results in people over 50. So they've gone back to the drawing board to look at different formulations. Now, it's really important, other than clinical efficacy, it is important to understand the immune responses to vaccines and compare them. What I'm going to show you now is a series of slides, and I'm going to show you how some of these vaccines actually generate a more robust immune response than natural infection. If you just, the blue here, this is the Pfizer vaccine, which is an mRNA vaccine. You can see the blue bars is the final dosage that they used. The other was a lower dosage. And the black bar at the end is the convalescent serum from someone who's had natural infection. You can see that even in people who are older, 65 to 85, your vaccine is giving you a stronger response than natural infection. With the Sinovac vaccine, which is an inactivated whole virus, it's called CoronaVac, they tell you that the geometric mean titer of the antibodies was lower from the vaccine than convalescent patients. So that's the opposite to the Pfizer. That's not great to see that the immune response is not as good as natural infection. The Bharat Biotech vaccine in India is similar to the CoronaVac. It's a inactivated whole virus vaccine. You can see over here in panel B, the blue, dark blue here is human convalescent serum, and there's the different vaccine doses with and without adjuvant, and there's the control. And it's not better than natural infection, may be similar to natural infection, remembering that the Pfizer vaccine was showing you better response than natural infection. AstraZeneca, they don't give you the data on convalescent sera, but they tell you that the vaccine response was higher than convalescent serum. So we'll have to see if there's any further data on that. The Johnson & Johnson, which is a human adenovirus 26, the grey bar at the end there is human convalescent serum, and you can see that in the people over 65, the vaccine response was not as good as convalescent serum, right? So it's not as good as natural infection. For younger people, it was similar. By day 71, maybe it was better. And this is the Novavax, which is one of the vaccines it's a spike protein vaccine. And this is a study in baboons. If you just look at the pink, the receptor inhibition from convalescent serum. So this is natural infection in the clear boxes. And there's the baboon who's been vaccinated. you can see that it looks better than convalescent infection. So the Novavax looks pretty good. These are the 3 published phase 3 clinical trials. So we've got the adenovirus AstraZeneca vaccine, Pfizer and Moderna, which are both mRNA vaccines. And really the mRNA vaccines look like breakthrough technology. That's a big difference in efficacy, 62% versus 94 and 95%. Remember that the endpoint here is symptomatic infection. It is not any infection, which is actually what we're interested in. We can only calculate the VE against any infection for AstraZeneca. We don't have the data yet for Pfizer and Moderna, although the Moderna data are available in their FDA application and looks pretty good. The AstraZeneca has probably much lower efficacy against any infection. The Novavax efficacy we've just heard released in a press release, not in a publication. 95% in the UK against the G614, which was the dominant strain last year, but 85% against the new emergent mutant B117, which arose in September, and even lower against the South African variant, which has an extra 2 regions that are mutated, 60%. But when you include people who are HIV positive, it drops to 49%. And that's telling you need really good vaccines for people who are immunosuppressed. You know, the standard vaccine is not going to be, you've got to make sure that immunosuppressed people are prioritized for high efficacy vaccines. We've also heard the Coronavac has an efficacy of about 50% against symptomatic infection. The J&J did a press release saying that their vaccine was 66 to 72% effective in the UK and US and 57% in South Africa. But the endpoint they're reporting is moderate to severe disease, which is different to the endpoint in all the other vaccines we've heard. That means it's going to be lower for the endpoint of any symptomatic infection and lower still for any infection, probably, because it's a similar, it's an adenovirus vectored vaccine. We'll just have to wait and see. Moderna showed there was no negative impact on neutralizing antibodies for the B117, but a 6-fold reduction against the South African variant. But they said that the levels were still expected to be protective. So this is just the bottom line of these vaccines, what we know so far. Really, the mRNA and the Novavax look pretty good. No, we don't have data on the variants from the mRNA because those trials were done before these variants started emerging. But you can see a reduced efficacy in the UK and then the South African variant. You could expect the Brazil to be similar there. The J&J I've put in lighter colours because it's not the same endpoint. This is not directly comparable. It is likely, if you're comparing it directly, it's going to be lower than this. But it's only 1 dose, mind you, which is really good. That's very useful in some parts of the world. And the whole virus vaccines really don't look as good as any of the others. So we know about the vaccine rollout. I'll skip that. The strategies we can look at are mass vaccination, targeted vaccination, or ring vaccination, which is essentially post-exposure prophylaxis. And many vaccines are efficacious as post-exposure prophylaxis, measles, hepatitis A, smallpox. They tend to have a lower efficacy as PEP, but they're still very effective. We don't know whether COVID vaccines will be effective as PEP, but they might be because of the long incubation period. So I'll just briefly show you some data from a study we've done looking at different vaccination strategies. I'm not sure how I'm going on time, but I might just skip the methods, but you can read this. It's on medRxiv. We used a hypothetical epidemic with 100 new cases on day 1 with contact tracing and case isolation in place. And we looked at scenarios of having a limited vaccine supply versus enough vaccine for mass vaccination. And you looked at New South Wales. So in the limited supply, we vaccinated young people, 10 to 29 years. We vaccinated older people, age 65 plus, and then all health workers plus younger people, to look at what difference that made. Essentially, these are kind of close-ups of the epidemic graphs. It's not a big difference. You're going to make a bigger impact on deaths if you vaccinate, this is deaths at the last graph on the right, if you vaccinate older people, but you'll make a bigger impact on transmission if you vaccinate younger people. And Indonesia has decided to target younger people because they have a very young population. Then this is quite relevant, I think, to the discussions we're having about rolling out vaccination. We've heard that we might be, doing 80,000 doses a week across the whole of Australia. Well, we took some data that came out of Victoria and New South Wales, each of which suggested they could vaccinate potentially up to 125,000 people a day. And so we put that in as our base case scenario, and then an ideal scenario of 300,000 doses a day. And really, when you're dropping down to 50,000 doses a day, which is much more than what we're currently planning, it's looking substantially worse in terms of the size of the final epidemic. And then looking at herd immunity, this is the vaccine effectiveness here on the first column is the effectiveness against any infection, not against symptomatic infection. And we don't have this data yet. I think potentially we could have vaccines that are sort of in the 70 to 80% effectiveness against any infection. We have to wait and see. But then you're going to have 75 to 85% of the population vaccinated. If the vaccine is only 50% effective, you can't achieve herd immunity. And remember that we don't have clinical trial data for children under 16. So initially, children won't be vaccinated. So it's only when children are able to be vaccinated that we can achieve this. This is just showing varied vaccine efficacy, from the lowest efficacy of 38% in the blue to the dark red, 95%. Makes a big difference in your ultimate epidemic size. This is post-exposure prophylaxis, and essentially, if you use vaccine, if you've only got a limited supply, and if vaccine effectiveness is reduced by 50% as PEP, then you can still get pretty good control of an epidemic if you trace and vaccinate 90% of your contacts. So in summary, a limited supply scenario, PEP is the best use of vaccines. We really should study the role of COVID vaccines as PEP, and Australia is a great place to do that because we haven't got an uncontrolled situation like many other countries do. Age-based targeting of limited supply will not really impact the epidemic, but it will reduce deaths if given to older people. I still think herd immunity is possible with a high efficacy vaccine, but you can only achieve that through mass vaccination. Really, if your VE against any infection is over 80%, 70 to 80%, you can achieve it. But if it's less than 70%, it's looking difficult. And we really need to know the endpoint of any infection. Using lower efficacy vaccines, of course, will prevent severe illness and death, and all of the vaccines seem to do that. But with that kind of scenario, we'll be living with SARS-CoV-2 long term. I think it's really important to look at the comparison in the immunogenicity data to convalescent serum. That's a good indicator. If the vaccine is looking better than natural infection, that's a big tick. But we also have to have standardized assays. So the choice of vaccines is important. We don't know yet. There's no data on what happens if you give one vaccine and then a different vaccine later. It's always beneficial to have diversity in a vaccine portfolio. The more choices you have, if things go wrong down the track, like the UQ vaccine falling out, it's always good to have more choice. And we will have more good vaccines available in the future. Timing and logistics matter. Mass vaccination is an enormous logistic task. We currently give about 5 million vaccines a year. So we're looking at potentially giving up to 25 million vaccinations. So you need vaccinators, cold chain, health promotion, and this will be the first time since the eradication of smallpox that any country has attempted mass vaccination. We've seen underestimation of the task in the US and the UK. A slow trickle vaccination attempt where it takes a year or two to get people vaccinated will leave us just living with COVID longer and higher morbidity and mortality burden, and having to keep using restrictions like lockdowns, etc., to keep things under control. So rapidly achieving high coverage is the best strategy. Just briefly to talk about the variants of concern that have emerged in the UK, Brazil and South Africa. They look like they are more infectious, up to 70% more infectious at least. And so the UK one looks like it's more severe. We haven't seen similar data on South Africa and Brazil yet, but that means herd immunity is going to be harder to achieve. Generally, the vaccines are still effective, particularly against the UK variant, but we've now seen clinical efficacy data from Novavax and J&J that is showing lower or reduced efficacy in people with mutant strains, particularly the South African strain. I think it'll be the same for the Brazilian strain. And also we know now that you're getting much lower efficacy in people who are immunosuppressed. This is just to remind you that in Manaus, Brazil, which is seeing a huge epidemic at the moment, it was estimated that 75% of people got infected last year in the first wave, and yet they're having a bigger wave now with this new variant strain, which means that wasn't sufficient to give them immunity against the new strain, which is really very concerning. So this just shows you that elimination graph again. With the variants of concern, you're looking at having to achieve a higher level of immunity to control the disease. Israel is the only country so far to have made a concerted effort to achieve herd immunity. They've used the Pfizer vaccine. They've got a population of 9 million. They've now vaccinated 1/3 of the population, with B117 being 40% of their infections. They only started on the 19th of December. So this is a phenomenal effort, even though they haven't vaccinated Palestinians in the West Bank yet, which is unfortunate. You know, vaccines, infectious diseases don't recognize those kind of distinctions. You know, if you don't control it in one population, you're not going to control it. The interesting thing, though, is even though they've had this phenomenal success, 40% of the cases now are in children and teenagers because they can't be vaccinated. So that's the likely scenario. You're going to see disease rampant in kids and teenagers when adults get highly vaccinated. But they did demonstrate a drop in R0 from 1.3 to below 1 by January the 21st. So the pandemic today is much worse outside our borders than it was last year. So the risk of breaches resulting in community outbreaks is going to continue. We really don't want one of these more transmissible variants taking off in Australia because it'll be much harder to control such an epidemic. So people at greatest risk are the people working at the international border, the hotel quarantine staff, including, you know, everyone working at the border, health workers and aged care workers, who are all, of course, priority 1A for vaccine. So in summary, if herd immunity is the aim, we need the highest efficacy vaccines. Rapid mass vaccination will have the best effect. We should be collecting data on post-exposure prophylaxis. Variants of concern, you know, all vaccines can be reformulated to match a vaccine escape mutant, but if you've got lots of people vaccinated and you've got good immunity in the population, you'll reduce that selective pressure for evolution of more variants in the future. So it really is more important than ever to try and control the disease with vaccination. Thanks.
Thanks very much, Raina, for that great summary, which is right up to date as always. So we have had a lot of questions. I might go to Mallory first. So there were a lot of questions. I'm going to try and summarize them, Mallory, about your sample, and particularly, I guess, if you could tell us a little bit about these consumer panels and what biases might be within those consumer panels, with particular reference to whether you think or have any access to data on things like religious beliefs, political persuasion, education level, profession, etc., and how they might have affected the responses in the various groups.
Sure. So I guess there's a lot of questions there. Just in terms of the occupation, I didn't have time to go into that in the presentation, but we did collect data, just generally speaking, on roughly what occupation people did have, and surprisingly, among healthcare workers, it was actually slightly lower than the average, but the proportion was highest among hospitality workers, which I think makes quite a lot of sense considering a lot of this sample was from the US, and hospitality workers have been shown to be some of the highest at risk as well, and also their livelihood has been impacted. At the time of this survey, a lot of cities still had lockdowns and restaurants were closed, so that clearly would be a driver of wanting to get vaccinated. We didn't collect any information on religion. We did collect data on education level, and I think as someone pointed out in one of the questions, tertiary degrees were a bit higher in this sample than is normal. I'm not quite sure why that is, but we didn't actually find any association between education level and willingness to take the vaccine, so hopefully that hasn't impacted our estimates too much.
And can you just describe what a consumer panel is, perhaps, in terms of recruiting from such a group?
Sure. So market research groups typically have these large panels where they recruit a lot of people, we're talking millions, to participate in various surveys and focus groups. Typically it's for, for-profit companies to get information on markets and things like that, but they've also been used more and more in research. The problem is that they aren't always recruited in a completely random way, and there's definitely some notable biases, especially around age and internet access, because typically they are all done online. So you kind of have to be able to not only have good internet access, but be able to use a smartphone or a laptop to fill out the surveys. So I know that's one big concern with those, is that, maybe you are missing a lot of people who just aren't able to do these kinds of surveys. They do try to give phones with SIM cards to people who maybe don't have internet access, but I would say that is a pretty big source of bias in these panels.
Okay, thanks, Mallory. Raina, if I could go to you, and I'm again trying to summarize some of the questions that have been repeatedly asked. So, are there any data on prevention of transmission and infection as against prevention of disease?
So the AstraZeneca phase 3 trial, the interim results published in December last year, do provide some data on that. And depending on how you calculate it, it could be sort of 20% or less, or against all infection to somewhere like 40%. So it is much lower than against symptomatic infection. And that's really what's of interest, how well does a vaccine prevent infection? Infection, full stop.
So I guess that then goes to another series of questions, which is, why do you think this is not eradicatable, the infection?
So the ideal characteristics of an eradicable infection, and eradication means it doesn't exist in the world, is that it should not have an animal host, because then you've got a reservoir of infection that you can't necessarily control, and it shouldn't have any major asymptomatic or pre-symptomatic transmission, because that makes it really hard to find every case. That's why smallpox was ideal. It was only infectious when you were fully symptomatic, and there's no animal host. For this virus, unfortunately, there probably is an animal host, bats and maybe some other intermediary animal, we think. And of course, asymptomatic transmission is a pretty major part of the transmission. So that's why it's going to be difficult to eradicate, probably impossible to eradicate, as well as the fact that it's going to be a long time before we see, vaccine access equitably through the whole world. There's going to remain to be hotspots in the world. Some hotspots because of lack of access to vaccines, but others, including the United States, I believe, because of vaccine anti-vaccination. Really, there's substantial, even health workers are refusing vaccine in the US, and I think the damage done in the last 4 years to trust in vaccines is going to take a bit of time to repair.
Okay, and how good a correlate, so you concentrated on the neutralization antibody titers, how good a correlate do you think that is of prevention of disease?
It's probably reasonable, but I think certainly all the people who worked on MERS and SARS vaccines really do strongly believe that the cell-mediated immunity is as important, if not more important, than humoral immunity. So the presence of neutralizing antibodies is a good correlate, but the absence of them does not necessarily mean there's no protection. There still could be protection from cell-mediated immunity. It's hard to say. Some of the trials have measured cell-mediated immunity, so yeah.
So there's also some questions that were concerned about the allergic reactions that have been reported, particularly with the RNA vaccines. And would you like to comment on that and how we might be able to find out what the allergens are?
Sure. So, yeah, both the mRNA vaccines, there have been reported cases of anaphylactoid and anaphylactic reactions and allergic reactions. So people who've got a history of anaphylactic reactions, or I think it's uncertain, there's speculation as to which components are responsible, and some of the reactions are anaphylactoid, not anaphylactic. So I think there's still a bit of work to unpick all that data and fully understand it, but what it highlights is you must be able to receive the vaccine in a place where there's someone who can resuscitate you if you have an anaphylactic reaction. I think that's a consideration for pharmacies vaccinating in Australia. I think you need to make sure that, you know, pharmacists are vaccinating, that they can resuscitate someone who's in anaphylactic shock.
So I guess the other thing is that in the product inserts and that sort of thing, the excipients and those sorts of things will be declared, correct?
Yes, yes.
So, you know, we will be able to be informed about if someone knows they're allergic to a particular component, that will be public knowledge. Okay, look, there's a lot of other questions there, but we have reached beyond the hour, so I'm going to close this now. Thank you for everybody for joining, and thank you particularly for our two presenters, Mallory and Raina. Thanks very much. Good afternoon.